Hello, and thank you for joining the podcast Emergency Minute. Your host is an emergency medicine physician who brings over 20 years of experience in healthcare. Dr. Parente will take you through some of the trending topics and challenges faced in the ER and all of healthcare. Join in the fight against misinformation. And don't forget to follow on social media at Dr. J. Parente. Now, here's your host, Dr. John Parente.
Welcome back to another episode of Emergency Minute. This is episode number 12, and on this episode, we're going to do a little bit of a Q&A. I've had multiple people reach out to me over social media to ask questions, and I'm simply going to answer them. Apologize for the long delay. Had to have a little bit of time off. Went to St. Martin to celebrate my anniversary. Happy anniversary to my beautiful wife. And if you've never been to St. Martin, I would highly recommend it. Very unique island that is half Dutch and half French. We happened to be on the Dutch side and had a very cool resort that was up on this hill, kind of overlooking the beach and overlooking where the airplanes land. If you haven't had the opportunity to see this, go on YouTube and check it out. They have these airplanes that basically, it's one of the most dangerous and yet exciting runways in the world, where these big giant jets are literally landing just feet away from the beach. And there's these crazy thrill seekers that are underneath there watching these huge jets take off and land overhead. It's pretty exhilarating. I saw the videos on YouTube. I thought, well, it looks kind of strange and looks kind of, fun at the same time. But seeing it in real person was incredible. It was definitely something I never thought I would be so intrigued by. So did some of that. Then also obviously had the 4th. Hope everybody had a nice happy birthday to America. Had a couple of parties and the baseball boys were over. So definitely kind of lost track of time. But we're back at it again here. Episode number 11 was summer medical tips. So if you haven't had a chance to check that out, please do so. But today we'll be doing that Q&A. And before I get started, as always, I wanted to thank every one of you for listening, commenting, sharing, giving reviews. Much love to everybody out there. This is just further proof that more people listen to this than my mom and my wife. First question, what are we going to talk about next? Let's talk about nursing. So this is from J.L. Stevens, who's one of my charge nurses that works with me at the hospital. And she asks, what does it feel like to work with such great nurses? That's a fantastic question. So a little bit about me. I started off as a nurse's aide back in the 1990s. Yes, I realize that dates me. But I learned very early on in my career the expression, nurses will make you or break you. I have the utmost respect for nurses. I think, honestly, people have no idea what nurses do, specifically in the emergency department. Things that would happen in public, if you go to Walmart or you're at the store, and what some of these patients do, people would get arrested. But in the ER, the nurses are asked, what could you have done differently for our satisfaction scores? Nurses have been assaulted, had broken bones, been spit on, cut, bitten, puked on, pooped on, the list goes on. I worked with a nurse once that had broken ribs, had a knife pulled on him. So it's absolutely incredible the things that we see day to day. And I think a lot of people don't realize that unless you're like someone that frequently goes to the ER. But I think there's like this subculture of patients that just like come to the ER. And so we kind of know who they are a lot of times. And they're kind of used to these kinds of things. But like if you weren't used to these things and you saw what we see every day, I think your jaws would drop. As far as an actual like bedside, understand that nurses are at the bedside and they need to be my eyes on the patient. I've cared for as many as 83 patients. That's sort of my high, and I've done it several times on a Monday in 12 hours. Now, that's with, 1 or 2 PAs, and I can't possibly be at the bedside of these patients for more than a few seconds. It's insane. So I rely upon good nurses to be my eyes, to say, hey, something's not right here, or hey, this person's getting worse, or hey, this person just spiked a fever, or this person has unstable vital signs. Obviously, if I have 83 patients in 12 hours, a nurse is going to have far fewer, but going to be at the bedside for a much longer period of time. So I can't speak highly enough of my nurses and ER nurses in general. They're just warriors. They're just total badasses. And without them, I would have a much different career path, I think, because they've gotten me out of some jams. They've definitely helped me. Like, hey, are you sure you want to give that medication? So I can't be grateful enough for the nurses that I work with. And I think society as a whole, just sort of has some debt of gratitude to these individuals, because what they do is is just absolutely undescribable unless you've been, side by side with them before. So I think it's a great question. I'm very blessed to be working with such a good group at my home hospital and some of the hospitals that I moonlight at. So, I think it's a great question, and it definitely, trust me, I can tell you that I do not take it for granted at all. All right, next question from a nurse practitioner that I loved working with was Michelle Jones. If you had the chance to do it all over again, would you choose the same path? Boy, that's a tough one to answer. Obviously, it's very rewarding to take care of people who are often at their most vulnerable time. And I think that's an honor to do so. People always want to talk about money. And I don't want to try to make this about money, but I think I can't answer the question without talking about money. Does this provide me the opportunity to take care of my family? Absolutely. But what does that cost? And I don't just mean the investment of getting into, college and medical school and then making no money during residency. But I mean like the actual physical cost, the emotional cost, the time investment, et cetera. So, you come out of college, most people are in debt, with college. I was fortunate enough that I was not. But then you go into medical school and, the vast majority of people going into medical school are in debt, and not just debt financially. I mean, debt of stress, weight gain, reduced health, all those things. And then residency is you're just doubling down. More debt because you're still paying for the old debt. You're not making any money. The pay is so low. You're working 80 hours a week, for 3 to 5 years. I mean, so most physicians don't actually collect a real paycheck until they're 30 years old or older. If you think about like a skilled laborer who, comes out of high school at 18 and, starts working right away, obviously they have to go to some sort of either vocational school or, something along those lines to learn a trade. But at the, just for the sake of round numbers here, they start earning income at the age of 12. They have a 12-year head start on building wealth and starting their 401k. Probably theoretically won't have as much debt as the average medical student, which I think right now the average medical student going into like their actual job is, hundreds of thousands of dollars in debt. I think there's definitely two different ways to look at that, but then if you look at like where is emergency medicine going? Well, I'm going to tell you something. It's not a good place. I haven't had a raise in a decade. I don't know how many people out there can say that. I don't know. I'm not whining and complaining about it. It's just a fact. And I'm not sure if anybody's noticed, but there might be a little bit of problem in our country with inflation. I've taken actual pay cuts, and then obviously not having a raise in 10 years is, something that you look at inflation and you're like, well, you're basically taking a pay cut every year. So when I hear my friends who are in business or accounting or marketing or anything else, and they're like, oh, I got a promotion. It's great. And, I'm moving up the business food chain here. I'm going on business trips. I even, go out to lunch with clients. Yeah, it does. It kind of makes you a little bit jealous because you're like, man, I'm lucky enough if I get to urinate in a 12-hour shift, much less, go take a lunch somewhere. I don't know what that is. I don't know what lunch is. So it does make you kind of question your life choices. I think the other thing you look at is vacations. We don't actually take, like ER docs don't take vacation time. So if I work an average of, let's just say 15 shifts in a month, it's not like if I go on vacation, I work less. I just have to work those 15 shifts in a shorter period of time. So it's a total blessing and a curse. It allows me to basically vacation every single month if I wanted to. I just have to squeeze and squeeze all those shifts into a shorter period of time, which kind of makes life very miserable anytime you take a vacation versus other professions where you actually get, vacation time or paid time off or, things like that. So, I think there's definitely some back and forth there. Ultimately, to get back to the question from Michelle, do I think I would do it again? I think I would, because at times this is rewarding. At times this is good for the soul. It does allow me to provide for my family and my kids. But I can tell you, I guess the caveat saying I would do it again is that I wouldn't do it again starting today. Meaning if I could go back and I had to fast forward my life and I had to start medical school right now in 2023, I don't think I would do it. And because I don't like the direction that medicine is going, after COVID, it just gave everyone an excuse to sort of let's see if we can do more with less. And this is happening across medicine, and it's really sad to see. Medicare cuts, insurances we're fighting an unfair battle against them. Unfortunately, patients, clinicians, hospitals are all fighting these insurance companies, which are uber powerful, make just absolutely ungodly amount of money And what are you going to do? You're going to go out and get a different insurance? It's not really a free market, right? Like you can't just go out and get a new insurance. So the direction of healthcare in this country is absolutely terrifying. And I think the general public has no idea how bad it is and how bad it's going to become. So I think, I'm definitely grateful for what I do. I'm proud of what I do. It's an honor to treat these patients in the manner that we do. Like I said, at some of their most vulnerable times. But I think the fact that I am sort of steering my kids away from having any interest in medicine should be more telling on kind of the climate of medicine right now. All right, we're going to switch gears here a little bit and answer sort of a scientific question or two. So this question comes from Tim Bradford, who asks, besides diet, what contributes to low B12 levels? And how long does it normally take to return to normal without a monthly booster? So great question. So B12 levels are typically due to either a lack of intake or you have malabsorption issue, meaning it's you're not absorbing the nutrients as you are supposed to do. So obviously low intake. So what are things that are associated with low intake? Well, reduced intake of animal proteins, such as a strict vegan diet. Now there's, what are some examples of decreased absorption? Well, you have multiple. There's bariatric surgery, Crohn's disease, celiac, pancreatic disease or insufficiency. And then you also kind of get some gastric atrophy, which just means your stomach is like weakened and the muscles aren't quite as strong. All muscles really aren't quite as strong as we age. And this is why oftentimes B12 levels will be lower in the older population. Now, anyone who has some of these absorption issues, if people are taking, vitamin supplements, which I do recommend as far as just taking at least a daily multivitamin, but a lot of that stuff isn't getting absorbed, and that's the issue. And there are other things that can cause this malabsorption, like thyroid disease, vitiligo, which was interesting when I read about that. And then there's medications, metformin, which is for diabetics, or PPI, such as omeprazole, Prilosec, Nexium, Protonix, etc. And then obviously the intake and absorption of B12 is closely tied to folate, but we won't get into that. So most commonly, what do we see? Well, we see B12 deficiency that is manifested by some type of anemia called pernicious anemia. So the question becomes, how long does it take to respond? Well, it really depends on the cause, because if the cause is simply, intake, well, then you just can increase your intake and that is great. But you often don't know what the cause is. Could there be an absorption issue or maybe a little bit of both? Depending on what you read, it looks like if you started on increasing your B12 intake or monthly injections or, things like that, you can see the production of cells that start to increase as early as 72 hours. You can start noticing that difference though in about 6 months, 6 to 12 months, depending on, different factors. So again, if the absorption is an issue, you may need some weekly injections. I think I said monthly earlier, but usually most patients are getting B12 on a weekly basis if they're doing so. So great question. All right, next question is from Instagram, Stephanie Jean 1917. So I appreciate the reaching out. What the heck is with pink eye this year? Both my kids had it multiple times. So great question. I do think that we've been seeing this more in the ER this year. I don't pretend to know the answer why. I can make an educated guess though. One of the things that we saw after global shutdown was one of the absolute worst and most virulent strains of RSV we've ever seen. And it was like all the viruses kind of got together and had a party and they were like, all right, this is BS. Like, we just had this global shutdown. We missed a flu season. We really didn't have much of an RSV season. All these, people were taking precautions, washing hands, social distancing. The entire world was wearing masks, etc. Like, that's going to have some global impact and impact on, some of the infectious disease elements that we're normally exposed to on a daily basis. And they came back stronger than ever. And I remember after, sort of the initial wave or two of COVID, and then COVID started dying down, and then people started, living their lives again, thankfully. Some of these viruses were just nasty. I mean, just nasty viruses. So, could that be a part of it? Now we're starting to see sort of the pink eye version, because most conjunctivitis or pink eye is actually allergic or viral or allergic, not necessarily bacterial. So I think, that may be part of it. And I'm not really sure, I don't know if anyone can answer, why on earth does everyone get bent out of shape with pink eye? Like these schools, daycare, employment. I know it's contagious if it is viral or bacterial, But it just seems like everyone gets all bent out of shape with pink eye. But knock on wood, I've never seen anybody, die from pink eye. I know there are certain ophthalmologic conditions, especially things overseas that, where patients have limited access to healthcare that can be devastating. Don't get me wrong. This stuff is usually very easily treated. It's rarely dangerous, and it's more of a nuisance than anything. So, that's my best guess as to why we're seeing it this year so much. But, definitely I agree with you. I think we are seeing it a lot more. All right, next question is from Dr. Kevin Lewis, who I have great respect and admiration for, my assistant director. So what to expect during a trip to the ER, specifically wait times, imaging, lab results, and then the admit versus transfer? Great question. So selfish plug here. If you haven't had a chance to listen to episode, Why Does My ER Visit Take So Long? I would definitely recommend doing so because I go over this in great detail. But for the sake of the podcast, we'll shorten this up. So here's a scenario that I paint out to a lot of the residents when I teach the residents. So if you think about it, if a patient arrives to the emergency department that's time 0, let's say you have a very efficient emergency department. If you're lucky, that patient is in a room within 10 minutes. Okay, not bad, right? Okay, so then the average, I wouldn't say average, a very good ER can then see that patient be at the bedside within another 10 minutes. So you're at 20 minutes already. So let's say that physician or PA or whoever's in the room for, let's say, 5 minutes. Now you're at 25 minutes. Then they come back to the computer and they put in orders. So we're at 30 minutes, right? And then let's say we're just doing blood work. Well, blood work's an hour. So you're already at an hour and a half and you're just now getting the results. Now, God forbid, you throw in CAT scan, which, by the way, takes probably at least 20 minutes to go get the CAT scan, 5 or 10 minutes to actually perform the CAT scan, and then another hour, if you're lucky, to have the CAT scan read. And then, of course, the thing that just absolutely is going to put me in my grave someday is the urinalysis, which takes forever. Obviously patients either have already urinated or they didn't know that they had to give a urine or something, and it just takes forever to get it. It could take hours for someone to pee, and then by the time we collect it and send it down, it just takes forever. So a lot of these delays, you can see are very not controlled by us. So if there's a delay with lab, that's not our fault. If there's a delay with CAT scan, we can't really do much about that. If the radiologist is backed up, which, by the way, every radiologist on earth is backed up because of what we talked about before. Everyone in medicine has to do more and more and more with less and less and less. This is having impact on, our flow through the emergency department. Now, you can have an ER visit where you don't necessarily need, labs and things like that. And we call that a treat and treat. So there's basically 3 different types of ER visits, right? You have the treat and treat, which means you come in, you have poison ivy, and I send you home and I give you steroids and we go about our business. Or you have someone that maybe just needs a quick workup. Maybe you just need an ankle x-ray. Maybe you just need a throat culture, something that's quick. And then obviously you have your full workups, which, can be as much as labs, urine, CT, x-rays, occasionally MRIs. So those obviously take a lot longer. So the ER is the ultimate place for management of resources. And I think this is where one of the shortcomings of residencies across the country exist. Yes, do they do a good job teaching medicine? Yeah. And should they do that? Of course. But do they fail in other aspects of, teaching, such as how do you manage an entire department? How do you manage your resources? Time management, things like that. So I think that's where, when I was teaching residents, that's kind of where I would focus a lot of times, because I think these residencies do a great job of teaching the medical part, but not necessarily the management part. So I think that's the key to the ER visit. If you have an ankle sprain and a critically ill patient comes in, you're going to get bumped. And most people understand that, but trust me, we have plenty of patients that do not. So I think that's kind of where we're at as far as that. But again, in delays with the radiology, lab issues, getting urines from patients, a lot of these delays are not our necessarily fault as much. You can only tell someone to pee so many times before you have to figure something else out or get a catheter or give them water if they're allowed to have it. So it's a huge issue as far as workflow. And the other thing that we're dealing with, of course, and I talked about this in the transfer crisis show, is just hospital availability, EMS availability. Even if you can transfer a patient these days, okay, great, congratulations, good luck getting into Cleveland, because most of the hospitals are completely full, and not necessarily full with patients, but just full because of staffing ratios of nurses, et cetera, and the nursing shortage. But, also then, okay, it's fine. You found somebody that's willing to accept your patient, that they need a higher level of care. Okay, you're going to try to transfer them. Okay, now we'll call for EMS. Well, guess what? Guess what EMS has to do? They have to do more and more and more with less and less and less, right? So there's fewer of them. And then all of a sudden, oh, well, it's 6 hours. Now it's 8 hours. It's 12 hours. And so that person's occupying a bed. Well, if that person's occupying a bed, then that means that there can't be somebody that's brought back from the waiting room. So those are some things to kind of consider. Again, I kind of covered these in more detail in a couple of other podcasts with the transfer crisis and why do my ER visits take so long. So I'd encourage you to check those out. But definitely a great question from Dr. Lewis. All right, another question kind of along the same lines here from Sandra Lay. And I'm paraphrasing here, but essentially she asks, how do we rush from patient to patient and only have a few minutes to spend with each patient and how this could be tied to managed care? So that's a great question. So, a lot of my friends jokingly, or I don't know, maybe they're partly serious, say that I have a PhD in efficiency. When I was in residency, my director, Dr. Michael Beeson, shout out, great director, was, he always told me, you kind of count the steps. You got to go to the X-ray view box. And when you do that, make sure you look at all of the X-rays you have pending. Don't just go look at your one X-ray that you're looking for. So I actually went to a national conference with my lead PA, Jansen Melsman, shout out. It's a phenomenal PA. And basically, we went to this Studer training, and it was very eye-opening. This was in Dallas, Texas, and this company goes across the country, and they figure out what's the best workflow, what's the best way for people to function within an emergency department. And they've studied this, and they've looked at different things. And it was interesting. One of the things that kind of stood out to me and to Jansen when we went on this trip was they had these like step trackers, and they would like track where nurses would walk in the department and where physicians would walk and how much time was spent walking versus actually like taking care of a patient, like being at a computer at a bedside or a bedside. So it was interesting to see that a couple of studies that they had looked at, nurses would spend like 80% of their shift walking around. And it's like hard to fathom. Like you're so inefficient that you spend 80% of your shifts. If you're, just walking around and instead of like taking care of patients. Now, of course they're going to get blankets. They're going to get water. They're going to get medications from the Pyxis. I'm not saying they're not doing anything. Of course they are. But then they implemented a lot of the techniques of like workflow and lean processes and things like that. And they were able to like flip it so that instead of it being 80% walking around, 20% doing healthcare, they were able to do 80% healthcare and then 20% walking around. Of course, the downside of that is then the hospital will probably say, well, we don't need as many nurses. Jokingly digress. So I think that really resonated with me and also with Jansen when we went to this conference was like, if you really kind of focus on what you're trying to do and accomplish that time and then try to be efficient about it, then that can make a big difference in the workflow in the ER. And again, we talked about the residencies. My job in the ER, I'm one doctor in the entire ER. I am the captain of the ship. Look at me. I am the captain now. A little reference there from any movie lovers out there. If the CT isn't done, it's my job to know why not. And it's my job to then call and say, did you not get the patient? Is the patient, it's done, it's not read. Why are the labs not back? Call the lab. Oh, we forgot. Or, oh, it's the machine's down. Or, oh, look, it's sitting over there on the counter. We're running it right away. So, I think, why hasn't the urine been given? We'll go talk to the nurse. Did they, has the nurse been, the urine's collected. It hasn't been sent yet. Like my job is to know these things. And it's really difficult to do when you have 50, 60, 80 patients in 12 hours. So, I think that's sort of, you have to be efficient to be an ER provider. And I tell my residents the same all the time. You're going to be the physician that when you walk in, all the nurses will either collectively say, oh, great, Parente's here again today. Boy, it's going to be a mess. What a mess. He's slow. He doesn't make good decisions. He's just going to take too much time. It's going to be a bottleneck. Or you're going to be the doctor that people, you come in and think, oh, thank God, Parente's here. Cool. Things are going to move quickly. He's going to make quick dispositions. Patients are going to get treated appropriately and quickly. So you have to pick like which one of those sides you're going to be on. And that's very near and dear to my heart that I'm definitely not going to be on the side where patients are waiting and things like that. Now, by the way, it does happen that these patients do wait if you have someone that's critically ill or you just, Mike Hirschman, love him, a physician assistant, one of the best I've ever worked with. Shout out to him. But he once always told me, you can handle volume or you can handle acuity, but it's awfully difficult to handle both volume and acuity. So absolutely. Absolutely well stated by Mike. Love you, buddy. So, all right. So the other thing we have to be kind of careful here about, because I am employed and I would like to keep my job globally, contract management groups, who are usually the teams that run the emergency department from the physician and PA standpoint, not the nurse's standpoint, they have definitely made this problem a lot worse. You have to see more patients, you have to do more things with less staff, fewer resources, and you're making the same or lower amount of money. So again, this kind of gets back to what I talked about before, the trend in medicine: do more with less, do more with less. And, obviously medicine is a business and people don't like to admit that or talk about that. It's sort of like the dirty little secret, but it's not a secret. It is a business. Companies have to make money, and they have to make money off of my back. And that's frustrating. They have to make money off the back of patients and nurses as well. And so, that's sort of the dark side of things. And I'm not going to go any further down there because I do enjoy my job from time to time and the ability to provide to my family. So I won't go further on that. But that is how we rush from patient to patient. I think the misconception out there maybe with the public is that we're just sitting in the back, twiddling our thumbs, snacking on whatever, food is remaining in the lounge. I can tell you, I've never worked in an ER where that was the case. Very, very hard workers in the ER. And like I said, you better have your PhD in efficiency, be able to see the kind of patients that we have to see these days. All right, next question comes from Annie Bulat, a nurse practitioner that I knew from way, way, way long time ago. So shout out, thanks for reaching out. The best thing I learned in medical school, the life-work balance and burnout. So this is a great question. And ultimately the answer is nothing. I didn't learn anything. Medical school is truly, you are a thimble under the waterfall, and you better hope that all the right stuff goes into that thimble and the rest just kind of pours over you. There's so much to learn. And in medical schools, and maybe it's gotten better. I mean, when I was in medical school, 10,000 years ago, they probably didn't focus on things like, coping, achieving balance, burnout, other important things, finance, life insurance, disability insurance, things like that. So, I think what I've learned over the years in my career from medical school residency is trying to achieve balance. And that's a lifelong struggle that I'm still dealing with. This applies to probably nearly everything in life, right? Like balance. So you got to celebrate the wins, I think, is another thing that I definitely learned and try to live by. But I also think in the emergency department, you specifically, and I'm sure other fields too, you have to learn to build walls to protect yourself from some of the absolute chaos and horror that we see, but then try not to take that wall home with you and your friends and family. And again, that's about trying to achieve that balance. If you build that wall, great, you can kind of protect yourself from some of the horrors that we see on a day-to-day basis. But if you take it home with you, then you're going to have like some real difficulty with maintaining relationships. And I think that's why, a lot of physicians, and I think specifically emergency department physicians, have a very high divorce rate. I think that's why they have, unfortunately, a higher rate of, suicide. Sometimes physicians like that end up in, alcohol dependency, and that's kind of a coping mechanism for them. So I think, I try to focus on find an escape, your happy place. Try not to have your primary escape be something, or your coping mechanism be something that's negative, like alcohol or, something like that. And I think the other thing is sometimes, and it's okay to say this now, but, I don't know, 15 years ago, you can say this, or at least not in sort of the bravado that is medicine, but like, don't be afraid to ask for help. A time of such unprecedented negativity on social media and society in general. I remember a quote, you want to know what the real world is, and go talk to your neighbor and get off of social media. And amen to that. Absolutely. If you start going on social media and you start looking at all this negativity, it's absolutely horrible and can really bring you down. So I try to stay away from that as much as possible, which is not always the case. But I think most people would be pleasantly surprised at how individuals will respond if you truly reach out and ask for help. So I think that's the summary for me is, sort of learn to build the walls, but try to, take them down at home. And of course, try to achieve that balance that we're all trying to achieve in life. I think those are the biggest things out there. And then if you're having trouble with those issues, I think reaching out and asking for help is obviously okay, because you never know what someone is truly feeling or thinking. All right, next couple of questions are going to be questions that were asked about when to go to the emergency department. So I think these are very good questions, something that probably a lot of people struggle with on a day-to-day basis. So we'll start off with Dr. Alex Walsh, one of my residents that has just recently graduated. Congratulations. Best of luck. So when do you go to the emergency department for high blood pressure? So this is one of my biggest pet peeves in all of medicine. I think I've talked about this in multiple other podcasts before. If you are a primary care physician, a family doc, a specialist, or a nurse practitioner, you're working in an urgent care, asymptomatic is not a medical emergency. Let's say that again. Asymptomatic hypertension is not a medical emergency. So the short version of when do you go to the emergency department? Well, the simple version is symptomatic hypertension. So what is symptomatic hypertension? Well, it's your blood pressure is high enough that you're having symptoms. It's really that simple. Are you having chest pain and your blood pressure is through the roof? Yes, go to the ER. No brainer. Are you having numbness and tingling? Are you having crushing headaches? Are you having blurred vision? Are you having, dizziness? Is your urine brown? Hopefully not. But if those are the things that are happening and your blood pressure is through the roof, then yes, you definitely need to go to the emergency department. If you've listened to my any of my other podcasts, such as Medical Myths That Just Won't Die, you've heard me talk about how broken medicine is. And that we can actually send a patient home with a blood pressure of 180 over 100, which, by the way, happens 50 times a day, every day. But we can't send them to the floor unless they lower the blood pressure to 160. Why? Because somewhere down the road, someone said, well, you better treat that blood pressure. Otherwise, we're going to have to call like a rapid response or a code on the floor. It's absolutely incredible. So despite concrete medical evidence that suggests that treating the patient is actually more harmful than good at that moment, we still have to do that to get to the patient to the floor. Treat the patient, not the number. So great question by Alex. When to go to the emergency department for high blood pressure? One of my lifelong friends that I've known since fourth grade, Eric Dean asks when to go to the emergency department with a headache. So this is a great question. And it's very difficult to answer, by the way. So medical disclaimer, if you're concerned about, headaches, by no means am I giving medical advice. You should seek medical attention. You have to look at this in different categories. So you kind of look at those with history of migraines versus those who've never had a headache. So if they've had a history of headaches and migraines, could this be something that's a change from their usual headache pattern? And most patients will tell you like, oh, no, this is very consistent with what I normally have when I get a migraine. But there are other things that we look for. We look for red flags. So like worst headache ever. Yeah, that's a red flag. If it's lasting longer than usual, normally my migraine only lasts for 4 hours, but now it's been, 12 hours, like anything that's sort of a change from their normal headache pattern. And then neurological symptoms, like, look, you can actually have neurological deficits. It looks like a stroke, but actually it's a migraine. But if that happens, yes, you need to come to the emergency department. So those are some red flags we look for. Now, for those who have not had history of headaches and really just don't get headaches, that's when we get back to those red flags. Was this a sudden onset of headache? Well, that's dangerous. Was this the worst headache of your life? That's can also potentially be dangerous. Is there a family history of aneurysms? Does the patient themselves have a history of cancer? Are there neurological symptoms? Or has there been a head injury, specifically as if the patient is on blood thinners? So my job is always to think of life-threatening conditions and, kind of think about what kills people first and then rule that out. Now, it doesn't always have to be ruled out with a CT scan or, that kind of stuff. But I at least have to think about it and then, put the patient at ease that that's not what we think is going on. So, and I think sometimes patients just want relief, right? Like I think patients that have headaches can be absolutely miserable. And sometimes they just go to the ER and they're like, hey, look, I just want relief from my migraine. And that's completely reasonable too. And I think we're good at providing that in the emergency department. Now, 100 years ago, I shouldn't say 100 years ago, probably 15, 20 years ago, one of the things we saw a lot of times were people that were being treated with narcotics in the ER for headaches. And obviously that's not appropriate at all. The American Neurological Association has a list of recommended treatments for headaches, and narcotics are like way, 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 way down the bottom of the list of like you've tried 700 other things and nothing else is working. And the reason why is a couple of reasons. One, if you start to give like high dose narcotics for something that's what's called non-verifiable pain, meaning someone that's having pain that you really can't like verify. It's not like a broken arm that you can see on an x-ray. The reality is you're going to have a lot more patients come into your emergency department that are dealing with addiction and opioid dependence and things like that. So it's not what we're trying to do, obviously, especially with the opioid crisis in this country. So that's the first thing. But secondly, there's actually medical reason why we don't give narcotics for headaches, and that is the rebound phenomenon. And that's a very real thing, that if you give the narcotic for the headache, they feel better, they go home, then hours later or maybe the next day, they feel much worse. There's definitely a rebound phenomenon, so that's why we don't do that. So we could talk about headaches for hours on end, but I just wanted to at least touch on Eric's question of when do you go to the emergency department with a headache? All right, next question is from Liz Davis. Shout out. When do you take your child to the emergency department versus the pediatrician's office? So this is a great question, very difficult to answer in a short podcast. I could do an entire podcast on pediatric medicine, family office versus going to the emergency department. But I guess the first question is, can anyone get into their pediatrician these days? I have no idea. I don't know how hard it is. Seemingly on my end, which I know is not accurate, but like we see, I feel like 1,000 patients a day that are like, well, we called the pediatrician and we'll get in August, so we came here today instead. Now, I'm sure that that's not the case. I'm sure sometimes patients, maybe they didn't call, or maybe they did call, or maybe they truly couldn't get in until August. I don't know. But it does seem like medicine is broken and heading in a very, very dark direction. But that being said, I'm sure that there are fine pediatricians out there that are right now just pulling their hair out, wanting to stab me through the microphone and through their radios. I'm sure there are pediatricians that can get, patients in quickly. I think the oversimplified answer to the question of when do you go to the ER with a child versus the pediatrician's office, well, basically, minor stuff, you can go to the pediatrician's office, and major stuff, you go to the ER. But I realize that that's very difficult to define. So let's talk about that a little bit. So, one thing I remember seeing early on in my career was a 16-year-old that came in by ambulance with a sore throat. And this patient had an appointment to see their pediatrician like an hour later. And and can sore throat be life-threatening? Yes, there are some conditions, relatively rare. Peritonsillar abscess can be quite nasty. Retropharyngeal abscess, which is even more rare, but also more dangerous. And then you have things like angioedema, which is like a severe allergic reaction that can cause your throat to swell, or most commonly your tongue. And then epiglottitis, which we used to see a lot more frequently back in the day, but with the advent of vaccines, something that nobody wants to talk about, or everybody wants to talk about, I'm not sure which. Epiglottitis has basically gone away, which is wonderful, except in some cases in adults, but I digress. But can sore throat be life-threatening? Yes, potentially it can be. But for the most part, like the vast majority of sore throats are just a pain in the butt. And this particular individual came in by squad. And I'll never forget the pediatrician caught wind of this. And I don't remember how, this was a long time ago. I don't remember if I called them or whatever, but they literally walked across the street to the hospital. They walked into the room, chastised the patient, the family, and everything. Was like, are you kidding me? Like you called an ambulance for a sore throat when you had an appointment to see me in 45 minutes from right now. And by the time they get you off this gurney, and I'll never forget the interaction. It was absolutely hysterical. The patient being just fine, of course. There's definitely, so what are some major, illnesses, major injuries versus minor injuries, minor illnesses? So, okay, obviously major injuries need to be seen in the emergency department. So, fractures, lacerations, motor vehicle crashes, blunt chest or abdominal trauma, those are kind of obvious. Minor injuries, well, yeah, can you have a sprained ankle and can your pediatrician write for you to get an ankle x-ray? Yeah, absolutely. And by the way, if there's a fracture there and they're not comfortable with it, oftentimes they'll send them to the ER for splinting and then like orthopedic follow-up. And I think that's okay. That's fine. Minor wounds can be managed in the pediatrician's office. Minor head injuries is another thing that we see a lot of in peds. And, look, to our pediatricians out there, a lot of times they send them over and say, hey, do you mind taking a look at him? Do you think he needs a CT scan? Do we need to further evaluate this? And that's fine. I think that's having a second set of eyes. We deal with this stuff all day long. So I think that's fine. Now, looking at, illnesses, illness, obviously major illnesses, difficulty breathing, someone who's actually lethargic. Now every parent in the world thinks their kid's lethargic when they're sick. That's kind of a dangerous word, but truly lethargic, truly like less responsive than they normally are. And I don't mean like the kid that's like got a fever that's like laying on the couch. I mean like opening and closing their eyes is very slow. Their muscle tone is very limp. Those types of things are obviously very dangerous. Neurological symptoms. Someone who's having severe abdominal pain should not be in the office of the pediatrician. And then things like obviously anaphylaxis. If someone's got a bee sting and they have a known allergy, that's somewhere where you probably should call 911 if you've had anaphylaxis before, because the thing that you need is epinephrine. And if you don't have an EpiPen, that can be life threatening. So, and then what are the minor illnesses? Well, I think most upper respiratory infections, sore throat, earache. I think if you have some mild abdominal pain, of course, it's okay to go to the pediatrician and be evaluated. If they think there's something more severe, oftentimes they'll send them to the ER. Hey, I think this is appendicitis. Let's rule it out. Let's get some blood work and either an ultrasound or a CT scan. I think that's very reasonable. And then most rashes, you can go to the pediatrician's office. But again, we see a ton in the ER. And I've said this before. I think, the emergency department is sort of the safety net for America. We're happy to see anyone and make sure that they are seen by a clinician, especially when it comes to kids. Do we get frustrated when we see, the frequent flyers in the ER and things like that? Sure. But with kids, I don't know, I have a special place in my heart with kids, of course. I've got 3 kids of my own. And I think that, we're happy to see these kids if it puts people's minds at ease, because this is by no means a perfect science. All right, final question is, and I hope I'm saying this correctly, from Susetti Badel, who reached out and asked, what has been your toughest case? Well, this is definitely something that's very difficult to answer because of federal privacy laws and respect for privacy of people I see on occasion. So I really can't discuss the case that is definitely my worst thing I've ever seen. And so out of respect of those individuals, I can't. However, I think just globally, the worst thing that I have to see is when kids die. I'll never forget the patient that died that was a 6-month-old that was co-sleeping on Christmas Eve, and mom rolled over and that was it. And they came into the ER, and it's just an absolute horrifying thing to see. And by the way, if people out there are co-sleeping, my God, there's so much evidence on this. Please stop, for the love of God. If you don't think it's real, then I'll tell you what, next time I have a dead baby come in, I'll just call you on the phone. You come on in and you watch me tell their parents that their kid is dead. And I think that will probably change your perspective. So please stop doing that, for the love of God. Another case that sticks out to me, at the time I had a 8-year-old son, and I had an 8-year-old boy that kind of looked like the same shape and size as a patient who was in a very, very, very severe car accident, and, ended up having to have an airway put in. And as I'm getting ready to put the airway in and we're medicating, we have an IV and everything, and the child's sedated and obviously not feeling any pain or anything at that time, thank God. And I'm about to put the tube down the throat, and there's this tear that just starts running down the side of his face. And I had a son that was the exact same size and shape as that little boy. And boy, did that hit me hard. That was, but I still, unfortunately for us, I wasn't even allowed to think about that. I couldn't even consider what that meant or what was going on at that moment. All I had to do is get that airway, secure it, and then fly him, to a trauma center. And the good news on that is, once in a while, something good does happen. I know that kid ended up doing well and was eating cereal like a day or two later and had been doing great. So, we see absolutely horrifying things, just absolutely horrific, that you can't even imagine. Things that are in horror movies, bed bugs crawling on people with mangled limbs, gunshot wounds, stabs, drunks that are impossible to reason with, who are covered in blood, spitting blood all over us because they had just been assaulted and their teeth are hanging out. And we see the absolute worst of the worst. And I think that's why we have this element of PTSD. And I think that's why we have such high rates of burnout and suicide and alcoholism. And I think that's partly why, residency spots are getting unfilled in record fashion this past year, actually this last 2 years. Typically emergency medicine has been very competitive because we, do shift work. So you don't have to run an office or anything like that. And the compensation was, competitive compared to other specialties. And, the sort of the work-life balance was great. And now that's all changed. Now the compensation is not nearly as competitive. Other specialties have gone up and ours really hasn't. And in fact, in some places it's gone down. And then we have to deal with, some pretty awful things. I think at the end of the day, my toughest cases to me are always, children dying or near death. but we just see and just horrific things. And I could do an entire podcast on some of the horrific things, which would not be very enjoyable. But I could also do a podcast on some hilarious things, which I could definitely do at a later date. All right, well, that's all I got for today. I appreciate everyone for listening. I appreciate my boy Drew for giving me the idea to do this Q&A, so much love to you. And thank you to everyone for doing any reviews or commenting, sharing on my posts on all forms of social media at Dr. J Parente. You can follow me on Facebook, YouTube, Instagram, and of course, TikTok. So thanks again for listening. I'll do another show here in the next 1 to 2 weeks. I won't take another month off, I promise. And as always, peace, love, and happiness to everyone out there. Cheers, everyone.
Thanks for joining us this week on Emergency Minute. Join us next time for more hard-hitting discussions on some of today's issues in healthcare. Don't forget to leave us a review on Spotify or follow on social media at Dr. J Parente.